Good afternoon. Good afternoon, everybody. It's 4:10 now, so I think we'll probably make a start. There are a bit more people joining us online than apparently going to be here. And I'll just introduce Dr. Lanre Ogunyemi, who is going to chair this session for us. He's a consultant in occupational health medicine, former president of the IMSG, and is now also the president of the Society of Occupational Medicine in the United Kingdom. Lanre.
Good afternoon, everyone. You're welcome to this afternoon's symposium for UCH residents on the UCH Residents Collaborative. We have quite a few things to talk about. The audience here is a bit sparse, but I understand that there are quite a few people online, so we're going to crack on with the symposium. First, I think it's going to be easier if the speakers come on stage. So if I can call Mr. Banji Adeoju, Consultant Urological Surgeon, Stockport Hospital, United Kingdom. Dr. Fumilola Olaolorun, Senior Lecturer, Community Medicine, College of Medicine, University of Ibadan, Nigeria. I understand Dr. Hakim Yusuf is going to be joining us via Zoom. He's Consultant Intensive Care Medicine, University Hospitals of Leicester, United Kingdom. Then Professor Eme Owaji, Professor of Community Medicine, College of Medicine, University of Ibadan, Nigeria. Also have Dr. Ebere Ugu, who is plastic surgery resident, UCH Ibadan. If you'd come on stage, please. And Dr. Habib Ogundikwe, who is also pediatric surgery resident, UCH Ibadan. Dr. Ugu, please come up. And is Dr. Ogundikwe. Okay. And Funsho Adedeji is already seated. So, first I will invite Mr. Banji Adeoju to give his talk. Thank you.
Thank you. Thank you all. Thank you, Funsho, for a really wonderful day you put together once again. Thank you to Professor Owaje, who has been supporting IMSG activities quietly but surely over many years. I remember she contributed a book chapter something 8 years ago, something like that. Thank you. So my topic this afternoon is clinical audit, principles and practice. And when I was Education and Research Secretary for the IMSG, the last book during my 4-year tenure was Research, Principles and Practice. And in that, there was a chapter on clinical audit, principles and practice. if there's any residents attending, and I'm going to use provost rules, if they are here, I have printed out copies of that original book chapter with me to hand out, only to people who have attended physically. So briefly, over the next 20 minutes, I'll go through clinical audit, what is it, a little bit of the history of it, principles and practice, the meat of the topic, and one example really. Wow, this thing is very soft touch for the next speakers. It's very soft touch. Clinical governance is a huge topic in and of its own right, and it's defined as a framework through which a healthcare organization is accountable for continuously improving the quality of their services and safeguarding high standards of care by creating an environment where excellence flourishes. That is the holistic, comprehensive definition of what clinical governance is. Under clinical governance, there are 6 pillars. Clinical effectiveness, huge topic on its own. Openness, research and development, huge topic on its own. Risk management, huge topic on its own. Education and training, actually what the medical school and resident training does, huge topic on its own. And then of course clinical audit, which is the topic of today's this lecture. So definition, I've lifted the definition from the National Institute of Clinical Excellence in the UK, and you will find when I discuss history a little bit later on that clinical audit hasn't been around for as long as some people may think. Again, I'm going to read verbatim because it's important, and I'll also appreciate that people are listening in online, so perhaps if I speak a lot more about what's on my slide, that will also communicate to the audience online. So, what is it? It's a quality improvement process that seeks to improve patient care and outcomes through systematic review of care against explicit criteria and the review of change. Aspects of the structure, process, and outcome of care are selected and systematically evaluated against explicit and specific criteria. Where indicated, changes are implemented at an individual, team, or service level, and further monitoring, and that's important, further monitoring is used to confirm the improvement in healthcare delivery. The Department of Health defines it slightly differently, the Department of Health of the UK, and defines it in a shorter way as the systematic critical analysis of the quality of medical care, including the procedures and processes used for diagnosis and treatment, the use of resources, and the resulting outcome and quality of life for the patient. Contemporary clinical audit involves 3 key areas. You can perform a clinical audit of structure, process, or outcomes. Outcomes, of course, is probably the most common audit, especially by surgeons like myself. But you can audit structure, for example, which means what do you need? What do you need to provide the service? For example, audit the availability of obstetric antenatal clinic in a given locality. You can audit the process, i.e., why, what, and how do we do what we do? And that's, for example, you can audit the booking process or waiting times for a particular clinic appointment or waiting times for surgery. For example, after a patient has been put on a waiting list. So it speaks to quality. Of course, patients want access to clinics. Of course, patients want timely surgery. Of course, patients want quick access to outpatient appointments. So that's why it's a valid thing to audit. And last, but absolutely not the least, outcomes. What do we expect from any given intervention? For example, most common example, success of interventions or surgery. I've put down there on my slide an online link to resources that discusses all these subjects in much greater detail. Clinical audit, a brief history. The ladies in the faculty and the audience will be pleased to know that clinical audit the history is referable to a lady. Florence Nightingale, very celebrated professional, who was serving in the Crimean War between 1835 and 1837. And she noticed that on her ward, patients were dying. And she believed that it was due to the unsanitary conditions on the ward. And she instituted an intervention. She upgraded the sanitary conditions on a particular ward and was able to demonstrate that there was a reduction of mortality, death, from 40% to 2% in the group in the ward where hygienic and sanitary conditions were effected and followed. Now, it's interesting though that, it's interesting though that it wasn't until 1983 before the UK government formally identified clinical audit as a thing worthy of exploration. That's interesting, isn't it? That's probably because the government is run by men. Be that as it may, in 1990, clinical audit became mandatory for all clinicians in the United Kingdom as a contractual obligation. And this contractual obligation itself has fueled the whole area of evidence-based medicine. Over the years, we have found that research and its burdens, and I'm sure the researchers will talk a little bit more about this, has been a hindrance, and it's low-hanging fruit. I call clinical audit low-hanging fruit, where you can perform useful, impactful clinical audit with reasonable expectation of outcomes, including outcomes such as peer-reviewed articles. So clinical audit practice, 5 stages. Number 1, identify a topic. Number 2, set standards, because you're always trying to test the information you're gathering against a set standard. Number 3, data collection. 4, analyze data. 5, implement the change, and never forget to close the audit loop, to consider re-audit. So you perform an audit, you identify the good parts and the bad parts in the outcomes of the data analysis, and then you institute change, and then a while later, 6 months, a year, 2 years later, you re-audit to see whether the changes you have suggested and implemented have taken hold, whether the culture of improvement has taken hold. So that's very important. So, how do you identify an audit topic? Choose carefully. Is there a need? It's very easy. There are guidelines in all our medical specialties about what to do something. For example, how do you evaluate the occupational health patient that walks into your office, for example? And I just picked that out of the air. But the point is, local and national guidelines are the useful starting point, a useful starting point to identifying a quality assurance topic. There might be a recent adverse event. I remember once, about 15 years ago, not in my NHS practice, in the private hospital where we spend a little bit of time working, we noticed an unexplained increase in enterococcus urinary tract infections. And because you're working in silos, there isn't actually the joined up thinking that is currently existent in the NHS. It was only by corridor conversation with my colleagues that we realized that a lot of us were also experiencing similar problems. And it boiled down to a problem in the decontamination and sterilization processes about 15 years ago. So it could be an adverse event, and you can choose, as a result of an adverse event, to audit the standards of a particular set of care being given. Has a patient made a complaint? The biggest issue patients make complaints about is always communication, communication, communication. So often patient complaints are due to poor communication, and sometimes it's worth auditing. Sometimes the response to a complaint by the organization is to suggest that that particular problem should be audited. So, summary though, in choosing a topic, use the SMART criteria. Be specific, make sure what you're auditing is measurable, be sure it's achievable. So, junior doctors that do, certainly in the UK, it's junior doctors, residents that do all the heavy lifting in audits, and we don't stay in one place for more than a year. So it's very important you choose a topic that you can start and finish. That's not to say an audit can't stretch into the person you're handing over to, but the important thing is to make sure it's achievable or agreed. Of course, be realistic or relevant and time-bound. So, for example, you can choose to audit a particular feature from the 1st of January 2023 to the 31st of January of June 2023. So it must be time-bound. So it's very important. Stage 2, set standards. Aims should be clearly defined. As I explained earlier, you find standards of care that are recognized, validated, and acceptable. What if there are no guidelines? Well, you can make your own up. What do I mean by that? You sit down with the leaders and seniors in the particular department and work out what you feel is a reasonable quality standard for that particular thing. And you can audit yourself against it. Thank you. Audit yourself or audit the service against it. Examples include improving service delivery of a particular procedure, patients being seen or treated in time, and also make exclusion criteria clear at the outset. This thing is so sensitive. Data collection. This is typically the hardest part, doing the audit. Very important that you build and maintain enthusiasm. Is it prospective or retrospective? Well, you have to decide that up front. Make sure what you're measuring is accurate. For example, you want, once upon a time, again, in my practice as a junior urological surgeon, we were auditing the time it takes to do a transurethral resection of the prostate. And there is that golden 1 hour where risk and patient detriment kicks in after 1 hour. So we audited TURP times because we had had 1 or 2 incidents of the dreaded post-operative hyponatremia in patients post-TURP. So we audited it and realized that perhaps we weren't paying as much attention to the time. So that is, we should be stopping at the time. Things are a lot better now. We should have been stopping at 1 hour, even if you've not removed the amount of prostate tissue you wanted to remove. Clear data pro forma for data collection, and as I said earlier, audit period should be clearly stated. Stage 4, analyzing data, compilation and comparison of data against your preset standards. Questions are, have the standards been met? Good if they have, but to what extent? You might have 100% compliance with a particular question and find only a 40% compliance with another question within your data set. And here, the comparisons against previous audits may be relevant. And here, a graphical display of data, it helps and aids understanding of your audience. And last but not by any means the least, implementation of change. This can be the most difficult part of an audit. It needs buy-in and enthusiasm. In the UK, you might find out that you have completed a successful audit project and you're about to leave the department, and therefore it's very important that the leaders, the consultants, the faculty needs to buy into this idea of clinical audit, buy into the idea of improvement, and most importantly, lead by example with improvement. Without that, it will fail. Yeah. And then, as I explained earlier, closure of the audit cycle, that is re-audit of that particular topic, which ultimately confirms whether or not all the hard work has paid off or not. Just a brief example, one of which I'm very proud of. In July 2018, I was perhaps only the third surgeon to perform transurethral water vaporization of the prostate in the United Kingdom. Certainly the first surgeon north of London in the whole of the UK in July 2018. So this was a very new procedure. I had managed to achieve institutional blessing to do the procedure. And of course, they insisted, they needed and wanted, and I wanted as well, to know the outcome of this. So briefly, transurethral water vaporization of the prostate, or the RESM procedure, is a new, minimally invasive option for treating benign prostate enlargement symptoms in older men. And it's superior to the previous techniques with a significantly reduced blood loss, significantly reduced hospital stay, it's done as a day case, significantly reduced sexual dysfunction rates. So it was very attractive to patients. So in this study, which as you can see eventually became published, I sent out 65 questionnaires to the first 65 consecutive patients that I had operated on. Since I had started in July 2018, I only picked out patients that had at least 6 months follow-up so that we knew whether the intervention was working or not. As you can see, it's a patient-reported outcome measure. 44 of 65 questionnaires were returned, that is 67%, and it was quite clear, sorry, it doesn't display quite well on the slide, that this was a positive, impactful, meaningful difference to their quality of life, with a significant reduction in symptom scores and a significant improvement in quality of life, with no incidence of new incidence of erectile dysfunction as a result of the procedure, and a much enhanced and improved ejaculatory dysfunction rate from 80%, which is classic for BPH surgery, down to 10%. So we concluded that the beneficial effects of RESM observed clinically were also perceived positively by patients in a real-world setting. So this was very good for me and good for my profile. This is published. Sometimes patients come into my consulting rooms with a printout of that article, and they seek me out from near and far. The point I want to make is, I'm not an academic. I am just a jobbing clinical urologist. This is an audit that got peer-reviewed, accepted, and published, and has made a difference in my professional life. So that's why I brought this as a good example to encourage the junior ones today. So, in conclusion, I've given a brief overview of clinical audit. It's an important, I would say, certainly in the UK, essential part of modern clinical practice. And I foresee a situation where the College of Medicine and the UCH once again blazes the trail in Nigeria for this particular aspect of activity. It's simple to perform. All it needs is leadership and enthusiasm from both the or juniors and the seniors. I believe it drives improvements and effectiveness culture, and we certainly, I believe, owe it to ourselves and our patients. Thank you very much.
Thank you, Banji, for that excellent talk. I think we'll take questions at the end for everyone, if that's okay. And I'm not sure if we have a means of finding out any questions online, but we'll look into that. Next, I'm pleased to invite Dr. Fumilola Olaolorun, Senior Lecturer, Community Medicine, College of Medicine, University of Ibadan, Nigeria, to talk to us about qualitative research. Thank you.
Good afternoon, everyone, and good afternoon, good morning, good evening to those who are online, depending on where you are. My name is Fumilola Olaolorun. I'm a women's health researcher, but I do have a lot of interest in qualitative research. So by way of an outline, this is what I'll be talking about. I'll start with a general introduction into qualitative research, and then I'll talk about designing a qualitative study, implementing a qualitative study, and analyzing qualitative data. For those who are familiar with qualitative research, this is just a snapshot, because I think I could talk about each of these for about 10 hours. So just a snapshot of what this is all about. I assume the audience is mixed, and I'm sure that there will be some people who are very familiar with qualitative research and others who are less so. So starting with an introduction, I'm sure everybody knows Albert Einstein, and I think he must have been thinking about qualitative research when he said, not everything that can be counted counts, and not everything that counts can be counted. So what is qualitative research? Both of these definitions are very similar. And I just put both of them up there to show you a more narrow and a broader perception of qualitative research. But basically, it involves the systematic collection, organization, description, and interpretation of data, whether this is textual or verbal or visual. It's very different from quantitative research. In qualitative methods, researchers ask what, they ask how, they ask the why of a phenomenon, rather than how many or how much. So you really can't count it, but there's depth to qualitative research, from the text, from the verbal responses, from the pictures, and other materials. So when should you use qualitative methods? If, for instance, you want to better understand people's experiences, their personal experiences with respect to a phenomenon, or you want to better understand the context in which they live or work, or you're interested in intangible factors such as social norms, you want to better understand gender roles, you want to better understand religion, religiosity, ethnicity, and how these factors influence other outcomes, qualitative methods may be a good way to go. If you're interested in conveying multiple perspectives on a given issue, for instance, you are interested in the perspectives of the children, you're interested in the perspectives of the parents, you're interested in the perspectives of aunties and uncles, interested in the perspectives of outsiders from a given community about a phenomenon such as gender roles in that particular community, you might be interested in using qualitative research for that. If you're interested in a very complex situation, there could be multiple levels. You need to dig deeper into the nuance and remove the levels one by one, remove the layers one by one, so that you can get a very deep and detailed understanding of that particular phenomenon or concept, then qualitative research would be helpful. If you're interested in the attitudes and the perceptions and the perspectives of any given phenomenon, qualitative research would probably serve you better than quantitative research. If you want to explore concepts or develop a conceptual framework or develop theories, then qualitative research would come in handy. So what are some examples of questions that you can ask using qualitative research? For instance, what barriers do older women encounter in accessing family planning services? In this context, by the time a woman is perimenopausal or menopausal, many people do not expect that she'll be sexually active. So such women may be very reluctant to go to a family planning clinic because of the context, because of the culture. They don't want people to be wagging their tongues. And so in order to better understand the barriers that such women face, qualitative methods can be useful. Another example is, why do women prefer to travel overseas to care for grandchildren instead of staying with their husbands? This is complex, it's multi-layered, it's nuanced, and so qualitative research may be a good way to address this. How do women decide what to do with a teen pregnancy? Again, multiple layers. In order for you to truly understand the answer to this research question, you might want to use qualitative methods. Now, there are times when quantitative methods are not enough. There are other times when qualitative methods are not enough. So you might want to mix both qualitative and quantitative methods and use a mixed methods approach. And this can be very powerful, but there should be a reason for mixing the two. It's possible that one data source is insufficient to answer your research question. It's also possible that you believe the second method will enhance the first, or that there's a need to enhance the original results you had. Sometimes people submit papers to academic journals, and the reviewers say, this is really interesting, but it lacks depth. Why don't you go back and do qualitative research in order to make this report richer? So now I'll move on to designing a qualitative study. Like I said, it's really just a quick touch and go. Each of these could be a 5-hour lecture on their own. So which type of qualitative study is most appropriate for the research question that you have in mind? If you're interested in answering a research question that's very sensitive, you might prefer to do in-depth interviews as opposed to a focus group discussion. With in-depth interviews, it's one-on-one. It's the researcher or the interviewer and the person being interviewed. So it's easier to create an environment where the individual you're interviewing can open up to you and give you detailed information, for instance, about their sexual life. If I was interested in conducting a study on LGBTQ in Nigeria, I definitely would not want a focus group discussion because of the stigma around it. And so an in-depth interview may be useful in that regard. With in-depth interviews, you can either have just a general in-depth interview, or if the person that you're interviewing has a lot of knowledge and expertise in an area, then you refer to that as a key in-depth interview. Key informant interview. So you can have either of these. We also have focus group discussions. Focus group discussions is where you bring together between 6 to 10, sometimes as many as 12, but usually not more than 10 individuals to discuss a particular topic. There's a moderator that presents the questions and then everybody responds. So the moderator is supposed to be like a facilitator to remain neutral and to get everybody to discuss the questions that have been predetermined. Usually it's semi-structured, and so sometimes you put your interview guide aside or your focus group discussion guide aside and talk about the new themes that are emerging from the conversation. You can also have observations, which could be participant, in which case the researcher is part of the environment, or it could be non-participant, where you're observing from afar. For each of these, field notes are very important. In qualitative research, you don't have numbers and percentages and proportions and odds ratios and multinomial regression and all this. But what you do have is the text from your field notes. What you do have are the pictures that you take on the field, if that is part of your research. And so the text is very important, and the researcher must be skilled in taking very detailed notes. about the environment, about nonverbal cues, about themes that are emerging. And any of these forms of qualitative research could also come with audiovisuals, like I had alluded to. So which tools will you use? For an in-depth interview or a key informant interview, you'll use an in-depth interview guide. The guide will have key questions. It's not like in a survey where you have question 1 and 4 options. It's very broad, and usually you start with the most broad question possible to just keep the person being interviewed or the group being interviewed during a discussion at ease. So you can have an in-depth interview guide, you can have a key informant interview guide, you can have a focus group discussion guide. And sometimes you're interested in more detailed information. So you could use vignettes or case studies as part of any interview or focus group discussion so that people feel more comfortable discussing whatever topic it is. This is really very useful for sensitive topics so that people can relax and talk to you as the researcher. Another tool that's useful in qualitative research is an observation checklist. Now, observation checklists may be used right there on the field, or it's possible you just keep the checklist in your mind and you fill it out after you leave the field. If, for instance, your research has to do with observing whether nurses in wards in UCH wash their hands in a particular way, and you have 10 things you're looking out for, if you're ticking these things there and then on the field, they will change their behavior. They know what to do, but that's not necessarily what they would do every day. So it's really important that you just observe, in fact, if possible, without them knowing that you're observing them, and later go to tick your observation checklist. Sometimes you're doing like mystery client interviews, where you present yourself in a clinic or in a pharmacy as a mystery client. And so in such cases, even though you have a checklist you want to fill out, you really can't fill it out until you leave the field. Then sometimes people use diaries as tools in qualitative research. You could have a time use diary. For instance, if you're interested in how women use their time, then you could give them a diary to fill out their time use in 15 or 30-minute blocks over the previous 24 hours. Or you might be interested in a food diary, and you give the individuals that you're studying a diary to fill out. These are all tools that are very useful in qualitative research. So who's in your sample? You have to remember that in qualitative research, the aim is not to be representative. You're not trying to be representative of the population from which you're drawing the sample, unlike quantitative research, where you want a representative sample so that you can extrapolate your findings back to that population. In qualitative research, you just want to better understand certain concepts. You want an in-depth understanding, and you're not trying to be representative. And because of this, you need to give sufficient thought to who will be in your sample, and you need to really think about who you're leaving out to make sure that the individuals that you have are the most appropriate and there's enough breadth for you to be able to speak about your research questions. I find having a recruitment grid very useful so that I can have an idea of the characteristics of individuals I would like to include in my sample to make sure that it's broad enough and including enough people with varied characteristics. You need to be intentional about sampling, and you need to document your process. Qualitative research is very flexible. There are no hard and fast rules. And so it's really important for researchers to carefully document what they do every step of the way, and in fact provide reasons for making the decisions that they have made. So for instance, if you're interested in learning about the experiences of childhood sexual abuse among commercial sex workers, one way to get them would be to use snowball sampling. If you know 1 or 2 commercial sex workers who were sexually abused as children, they are more likely to know about other people than the general population. So you're able to reach out to these 1 or 2. You ask them for references. You could give them a card to give these other people who have experienced similar situations. In the example I gave earlier on too, if for instance you want to study LGBTQ among medical students, for instance, if you know one or two and you're able to reach out to them, they will be able to help you to pick out others. And that's called snowball sampling or chain sampling. All right, so what ethical considerations are important? Ethics is important in any form of human subjects research, but in qualitative research, I'd just like to point out a few things that you definitely need to keep in mind. So confidentiality. In qualitative research, the sample size is relatively small compared to quantitative research. You could have a sample size of 30 or even 15. You could have a sample size of 60, depending on how large your sample is. But it's not like quantitative research, where, for instance, in the Demographic and Health Survey for Nigeria, they have a sample of over 33,000 women. So because of the fact that you're dealing with a much smaller sample, confidentiality is extremely important. Some people have particular ways of saying things. So if you're quoting them in a paper or in a report, you need to make sure that you're quoting them in such a way that the reader will not be able to deduce that so-and-so said this, especially when you're adding an attribution, a 33-year-old lecturer in the University of Ibadan, for instance. So it's really important to keep in mind confidentiality. Privacy is also very important while collecting the data. So there should be visual and auditory privacy. That's important in surveys as well, but even more so in qualitative research. Make sure nobody is actually observing you, that you're in a quiet room, preferably with a closed door, and that nobody is listening on the other side of the door. Informed consent, just like in any other form of human subjects research, is important. For qualitative research, it's nice to get their consent in writing, especially because if you end up using their quote, you don't want someone to sue you in the future. All right, so moving on and shifting gears again to talk about implementing a qualitative study. Here I just have a lot of questions to help you to think about how you would want to conduct your study. What kind of people are you interested in? Is your research question focused on women or men or couples or children? Are you interested in pregnant teens or health workers? How many people are you interested in? There's an important concept in qualitative research called saturation. So even though you do not do a typical sample size calculation like you would in quantitative research, you have a range, you have an idea of the number of people you want to speak with. So when reporting sample size in the proposal of a qualitative research, you may say 15 to 20 women, for instance, of reproductive age, rather than saying your calculated minimum sample size is this, because you really don't know at what point you will reach saturation. And you attain saturation when you're hearing nothing new. You've talked to 10 people, by the time you talk to the 11th, 12th, and 13th persons, they're not telling you anything new. They're saying exactly the same thing as the first 10. Then you know you have reached saturation. Then where are you going to recruit these individuals? Are you going to their homes? Are you going to recruit them in school? It's really important to think about this carefully. How will you recruit them? I was warned. All right, so how will you recruit them? Are you going to recruit them directly or through gatekeepers, or are you using snowball sampling? These are all important questions to ask yourself. Are you going to recruit through online groups, through WhatsApp, using posters and flyers? Where are you going to interview them? In this world of virtual meetings, are you going to have a Zoom call with them? Are you going to meet them in person and have a face-to-face interview? You really need to think carefully about all of these, and it should be part of a proposal for your qualitative research. And what is the appropriate venue? A neutral space is the most appropriate venue, and you need to determine what is neutral for your participant. So if you're conducting a study that has to do with health services research, you may decide that the neutral space is not the health facility. You might need to use a town hall or an eatery nearby so that your participant feels comfortable. All right, so talking a little bit about challenges and opportunities in conducting qualitative research. I've talked about some of these indirectly, so I'll go through this pretty quickly. When you have focus group discussions, it's important to plan well ahead. The time allotted isn't enough for me to walk through the process of focus group discussions, but sometimes you have too few people show up or too many people show up. Ideally, if you're trying to get 6 to 10 people, you'd want to invite 12 to 14 people, but you need to make your rules and regulations clear from the beginning. So it's important for you to really think about this. Sometimes people are very dominant. It's just their personality. When they're in a focus group discussion, they want to control the discussion. And so you as the facilitator or the moderator need to take charge and need to be able to say something like, Mrs. B, thank you so much. I can see that you're really an expert in this area. You have very interesting responses, and I really appreciate your contribution. However, I would like to hear more from Mrs. C. So you don't put them down, you kind of feed their ego, keep everybody happy, and ensure that you have peace in the discussion. Some people are very quiet, and you need to really reach out to them. Sometimes you have gate crashers who were not invited, but they come. So you need to be able to carefully explain the nature of the research and that you're unable to accommodate them without creating a scene. So talking about analyzing qualitative data. So thematic analysis is most frequently used, and this could be manual or it could be computer assisted. I see that my time is about up, so I won't go into details here. But a variety of manual in 1 or 2 days. For qualitative research, you have to read through the transcripts over and over again so that you get a sense of what people are really saying. And the text, the quotes, are the data that you're using, not numbers. So why should researchers be concerned about the quality of qualitative research? Many times researchers can bring their own biases into the study, and so it's important that they are aware of this. And some people who are purely quantitative researchers do not think that qualitative research is as sound and solid as, do not think that qualitative research is as sound and solid as quantitative research. And so it's really important for qualitative researchers to be able to evaluate the quality of qualitative research. And there are a variety of ways to do this, and I'll just point out one. Reflexivity. It's very important for the researcher to be able to look inwards and clearly articulate the biases that they may be bringing to their own study and document this in papers as well. So there are ways to control bias and errors. You cannot completely remove them, but you can definitely minimize them. There are biases that come from the researcher as well as biases that come from the participant. And I'll wrap up there. Thank you very much for your kind attention.
Thank you, Dr. Olaoloru. We're running roughly about 20 minutes behind. Our next speaker on the agenda is Dr. Hakim Yusuf, who is a consultant in intensive care medicine in University Hospital of Leicester, United Kingdom, but he is not online. So I'm going to change the agenda slightly, and I will invite Professor Eme Owaje, Professor of Community Medicine, College of Medicine, University of Ibadan, to talk to us on how to apply for grants. Thank you, Amy.
Thank you, Lanre. Good evening, everyone. Good evening, Professor Shokumbi. Nice to see you. I'll be talking about, well, they said how to apply for grants, but basically at the end of the day, what people want is the money to do the research work. Money to do the research work. Let's keep our eye on that. So, okay, so the objectives of this is just basically to note at the end of this, we expect that people will be able to identify the different types of grants that are available. Oh, we were warned. Okay. I think excuse me. And then recognize the keys to successful grant writing and know the key components of grant applications and identify funding organizations. So grantsmanship is basically how you write a successful grant, and it refers to the skills required for securing funding. Because you can write, but your proposal might not be acceptable because you don't have the skills. And we all know now that funding, getting grants, is a major enterprise for any organization, any academic organization globally. And then for most research grant applications, the process has become increasingly complex. You can't just send an email. There are different, what you call organizational representatives. There are quality checks set in place because of the liabilities. Most of these funding organizations don't want you running away with their money. And also, research has become very complex. It's not just one researcher, particularly biomedical research. It's really complex, and there have to be different layers ensuring that the quality of the research that is being done is done well, because it's from the taxpayers' money or foundation money. So people want to know that that money is not going to walk away. Then it's highly competitive, and the idea must be innovative. It must be capable of advancing the current status of research. So it's not just research for the sake of research, but there must be qualities in that proposal that indicate that this is going to add to new knowledge, or the outcome, output, or impact will add to development in the society. Then the proposal must be compelling and well written. So what are the types of research grants? There's collaborative research grants, which is what we do mostly now in biomedical research, because it's not just the small research. Yes, you can do the audits, you can do the other things, but the ones that are funded are usually collaborative research grants, which might be interdisciplinary, multidisciplinary, multiple sites across many nations. So that's part of the complexity that we have. And it's usually interdisciplinary, and we've mentioned this, and led by senior researchers. And there's a team of co-investigators. And since we are talking about residents, or talking to an audience of residents here, I would encourage residents to engage with other senior researchers. Quite often people feel they want to use me, and let me just do what my training is providing for me. But you can't get into research until you actually you apprentice with somebody else. I remember from my own story, Professor Yejide was in the department when I got there. I think I'm just a restless person that's always looking for something to do. And she provided the mentorship that I required. And she put me through the basics of research within my second year of residency. But I had to make myself available. And there were things that I learned that were not in the textbook. And as a result of my availability, I had opportunities to engage in research quite early. And I'd like to say thank you to Dr. Funsho Adedoju with the way that you have mentored the residents in surgery. So that's important. And because a lot of the senior researchers are the ones that get the major grants, and they have teams, so you can plug yourself into those teams. So fellowships, individual research grants can be provided to the fellows to have a particular time to focus on particular types of research. We'll talk about NIH. NIH has some individual mid-career research grants that are available. So time is provided for that person through the funds, and then funds are available. Then you have targeted grants for early career researchers, mid-career researchers, and the professorial level. MRC, the Medical Research Council, and Wellcome Trust have this kind of layered or tiered kind of research. Then there's ring-fence research, that funding that's established to establish and the progression of particular researchers that are extremely good. They've been identified as researchers, maybe in the neurological sciences, and their ideas are very distinct and innovative. So funds are provided for those people to continue their research in those areas that they've identified. Then there are networking grants. Sometimes these are provided by associations or even NIH, that they're starting with a small grant for people to come together and establish an idea. And then they can develop that idea and then have a pilot and then subsequently apply for a larger grant. So you have small grants as well, travel grants, and travel grants support researchers to go for short-term research projects in other places, or maybe they've collected data, maybe samples in UCH, and they don't have the resources, the lab resources to process those particular samples. So they can go to another institution that has the particular resources or the lab resources to process them. And then knowledge transfer grants or industrial partnerships. For instance, maybe like the kind of surgery that Banji talked about. If there's a particular tool that has been developed, or a surgeon has developed that tool, and it can be that knowledge, that prototype can be taken up by the industry and developed and can be sold at a larger market level. So that's the thing with research now. It's really gone beyond just what we do. We need to think broadly. We need to think of partners within our own departments, within our own institutions, and then having industrial partners as well. Even in terms of like incubators, can we develop location-specific incubators that we can partner with bioengineers biomedical engineers to further expand, and then partner with the industry to roll out these things on a larger scale. Then knowledge transfer grants, okay, that's important because there's a lot of emphasis on transferring the knowledge that has been developed through our research. Most of the time, for us researchers, we feel once we publish, it's over. But how do we engage with our larger public? And this has become particularly important in the advanced countries because the taxpayers want to see what their funds, their taxes are being used in terms of research. So they want a return for the investment. So conference grants are also available to disseminate the research findings. And what are the key points of a research proposal? I'm sure we are all aware of this. The background justification, CVs are important, data management plan, letters of support. Letters of support just say the institution is ready to provide time, provide the resources, or sometimes some things in kind towards this research grant. Then the roles and responsibilities of the various members of the research team. It's not just because Dr. X is my friend. What exactly is he going to do? Or Dr. X is my mentor, and it's payback time. No, everybody, it must be apparent what everybody is going to do. Then submitting grant applications. This is crucial now because a lot of the applications are online submissions. So you must have the registrations. You must know that your institution has the registrations, and those registrations are up to date, because a lot of these things have to be renewed. And there must be people within the institutions that submit the applications. And it is not at 5 minutes to 5 of the deadline that people should take the applications, because there'll be a lot of people that will be submitting on the last day, and there'll be glitches. So this is critical. Then your project narrative is very important, and the significance of the study is something that you have to pay a lot of attention to. And some of these proposals are actually, they just tell you 12 pages, but it's 12 pages of crunch, because you have to put a lot of information in there. It has to be very concise, and they have specific instructions. So it's important. And then you have to show the feasibility and the value for money. Then you have a comprehensive description of the project, provides a background to the project as well. Literature review is critical. There's no point just digging up any literature from somewhere that's been there for 20, 30 years, unless it's crucial. So in terms of getting money for a grant, you must be on top of your game. You must have a team of people that are also getting your literature in place, because there are so many other people that are applying. So you must show that, I know what is going on, I know the gaps, I know how to address those gaps. This is how my particular project is going to address the gaps. And then you should have a definite research problem. What are the questions? What are the aims and objectives? And then your research methods must be well documented and must be appropriate. That's where you'll also probably need an epidemiologist or a statistician on your team, because talk about calculating sample size, what is relevant, what exactly am I focused on. Then outlines the project management and delivery plan. This is critical, and a lot of grants now actually have a project manager. So as one researcher, you cannot handle everything. So you need somebody that is very familiar with the grants, can run the grants, can contact various people that are on the project. Work plan is important. Dissemination plan is also important. We've mentioned that publications alone don't cut it now. There must be, summaries that are clear, even to the lay public, that say, this is what this grant has done, these are the findings, and these are the implications. In some cases, you have to engage with people in government at the primary healthcare level, secondary healthcare level, or tertiary level. Then budget and budget justification. This is extremely important, and that's where you probably have to engage with the members of the research management office or research manager, the team, whoever is responsible for that in your institution. Letters of support are extremely important. They have to show the role of the various institutions, the collaborators, what are they bringing on board? Is it lab? Is it the data collection? And then how will each person be involved? And the critical point is that it's not just, we are so glad to be part of this project. We are honored. And, no. It's like, what support? What is the purpose of the research? Sometimes the researchers have to do a draft. Even for the collaborators I've had in the US, they will provide that draft because they know that will also be looked at. So the purpose of the research, anticipated outcome from the research project, what is the role of that institution? And even sometimes the background relationship of that collaborator, of that both collaborators have had. We've done a number of projects over the past 5 years. We've engaged in similar projects, and we have, been able to form a team that can clearly deliver on this project. And then what is the contribution in cash or in kind? Quite often in our environment, we feel we cannot give a contribution, but there's something that is being given, be it the manpower, be it the technical know-how, and also engagement with the people at the various levels of that the research will be conducted in. So contributions in kind can also be brought on board. Then it must be on a letterhead and signed and dated. So you also need to talk about the impacts of your proposed research, to the end user, and how will it be beneficiary to them, and the activities that will be undertaken to ensure that this particular project has impact. There was something we did on remote consulting. So what would be the impact of that? Particularly, that was done during the time of COVID-19. So what was the impact that, we could actually demonstrate that primary healthcare workers could engage in remote consulting for people with chronic morbidities, and they wouldn't have to come to the clinic so often if remote consulting was used. Then it must be innovative and creative. Is my time up, Larry? Oh my goodness, okay. So where do you get money from? All these different sources. Larry, I think you were not fair with me on time. Your passion. Okay. Let me just run through this. These are the various sources of funding that are available. You'll get the slides. I just want to quickly get to NIH. NIH is a major funder of biomedical research across the world. They spend up to $30 billion on research, though most of it goes to the United States, but there are particular research studies that are, we have collaborators in sub-Saharan Africa. So there are 27 institutes and centers. The main center for us in sub-Saharan Africa is the Fogarty International Center that provides for research funding for our research. So you can visit these websites. Then the UK Research and Innovation, UKRI, there are a number of research funding that's coming from their partnerships with UK partners. And then a key organization is the MRC, the Medical Research Council. So that's there. Then Wellcome Trust, there's EDCTP. So there's so many funders around, but the thing is that link up with collaborators, with your colleagues in different parts of the world. And never think you're at a disadvantage because you're in Nigeria. It's amazing what we know about our environment. I tell people that it's a shame that people will come from other countries, stay here for 2 weeks and become the international experts in sub-Saharan Africa. We are the international experts in sub-Saharan Africa, and if people are coming to do research here, we must be willing to showcase that we have the brains and we have the knowledge and capacity in this environment. NGO funds for NGO is somewhere you can get some information for small projects. It's only like $50 annually. And you can get projects for maybe creating awareness about breast cancer, prostate cancer, etc. Some community-based studies. So thank you very much for listening.
Thank you, Amy. That was such a practical and detailed talk. I wish that we had given you more time, at least equivalent to the others, because I think a lot of the residents will learn from that in terms of obtaining funding. We've had quite a few good talks so far, and all of them containing very good practical things for residents to take away. Next, we're going to go to Leicester to invite Hakim Yusuf, who is a consultant in intensive medicine, to talk to us about systematic reviews and meta-analysis. I'm curious as to how practical he can make this, but we'll see. Dr. Yusuf, I understand that with the wonders of technology, he's going to be taking over the screen as well as this microphone.
Thank you very much for inviting me to this, and I wholeheartedly apologize for coming late. I didn't realize Nigeria was 1 hour ahead. I'm just trying to share my screen. Hello. Hello. Can you hear me? No, it's working now. Hello, can you hear me? Okay. Hello, everybody. My name is Dr. Hakim Yusuf. I'm a consultant intensivist in Glenford Hospital, Leicester. And I want to just take you through very quickly a brief overview of systematic review and meta-analysis. This talk is not going to be very in-depth. It's just going to skim across the basic principles of systematic review and meta-analysis. So in terms of the definition of systematic reviews, if any of you are pursuing a PhD, this is a very core part of starting out a PhD program, in the sense that you want to review the evidence in your field of study to identify the gaps, and that informs what you do next in terms of your PhD. So systematic review is meant to be very high level. It provides an overview of current evidence in a subject area, and the key to it, the key word in the definition of systematic reviews has to be high quality research evidence that's synthesized together in order to provide an answer. So I'm sure a lot of you have seen this. There's a hierarchy of a known hierarchy of different evidence, and if done well, and I think the key word there is if done well and all the rules are obeyed, a systematic review belongs to the top of the tree in terms of evidence generation. So when we're writing guidelines and reviews for different when different societies are putting guidelines together in terms of the grading of evidence for different guidelines for evidence in managing any condition, this is how they are ranked, and systematic reviews are put at the top. But it's actually also important to appraise systematic reviews, because not all systematic reviews holds that level of evidence as high as a very well conducted randomized controlled trial. So this is the process of, this is what you go through when you're conducting a systematic review. You formulate a question, identify relevant studies, extract data, you assess bias included in the study, and that's a really key important thing if you're going to do a systematic review properly. If there's too much bias in the individual studies contributing to systematic review, it actually biases the data. Then the synthesis of the data. Now, at level 5 is when you move into a meta-analysis. So your systematic review could end at level 4 plus. And I say plus because if, for instance, you've done your systematic, you've extracted your data, and you find that actually there isn't enough to conduct a meta-analysis with, you can then move on to a systematic review with a view to just providing qualitative rather than quantitative synthesis of data, which pretty much means that all you're just doing is descriptively presenting what's out there in the literature and highlighting the lack of evidence. Now, in that context, what you would realize is that actually there is a need to have more quantitative data in the future. So this is why this is one of the key steps when you want to do a new study or you want to do a PhD, to do a systematic review in your field of study. It helps you to actually gather and synthesize the best data in that field. Then there's interpreting the evidence, writing it up, and the guidelines towards writing it up. And then as time goes on, is the need to update review because more evidence comes out. So it's really important that the first key thing when you're doing systematic review, you need to have a review question. What is your question? It should be precise, and we use the PICO skeletal framework to actually really define our research question. PICO stands for P, participants, I, intervention, there's a control group and a comparison set, and then there's an outcome of interest. What's very, very key about putting studies together to meta-analyze them is that the outcome of interest needs to be the same. There's no point comparing a 30-day outcome study with a 1-year outcome study. They're very, very different. So you kind of need to ensure the outcome is very well defined in your PICO question. Now, in terms of identifying relevant studies, it is the nitty-gritty. It's the pain of doing a systematic review, because you have to painstakingly do your literature search and try and identify. So what's really important is to have a study identification plan. So you have criteria that rule in and rule out your studies, and that has to be adhered to. What's very important to make systematic reviews very, very robust is that in the identification and inclusion of studies, it shouldn't be done by one person. It's important to be done by more than one person, because that actually helps to improve the validity. And when you have conflicts, you have a conflict meeting and resolve those meetings. It's also really good to use a platform. There are so many platforms there to help identify studies and extract data, such as there's Covidence. There's Covidence you need to have a subscription for, but there's other free ones around there. So it's important to use that platform and to have independent, blinded extraction of data between two sources. Now, what I would really encourage you to do in terms of searching for data is to learn about your mesh terms. So the mesh terms for your studies are this is a string coded terms used throughout medical literature to identify pathology. What can help you is for instance, you want to study the evidence for, I'm just hypothesizing now, the evidence for steroids in ARDS, which is what I look at every day. There has been a big paper called DEXA-ARDS, and that paper, when it publishes the data, it will have keywords. Now, those are your key, that's where to get your mesh terms from. You take those keywords and you go on PubMed, and there's a mesh term area in PubMed. Put those keywords in and use as many mesh terms as possible so you can get as many papers as possible. Now, once you've gathered all your papers, then you go through the painstaking work of including papers that are in and papers that are out. Now, there is a thing with non-English journals, and at the moment we're getting a lot of data and literature from China and from the Chinese-speaking world. In the past, we've always excluded these studies. Now we include them, but you've got to have a way of interpreting those studies and contextualizing into the rest of your studies. Now, there's also the grey literature, and this is really important. There's unpublished work that you could include in your meta-analysis, and you have to, and sometimes identifying those studies often requires more work beyond going on the internet, going on PubMed or going on Ovid to try and look for studies. It entails, really dedicated work. So this is the work in doing a meta-analysis, getting all your studies together. Sort of a sample flow chart there of what the process is. You identify your search-based data, look for additional data, remove duplicates, then you screen your data. And if you look at it, what's happened there is that most of the studies were screened out, and that's what tends to happen when you're doing a meta-analysis. You tend to screen most studies out, then you narrow down to a few studies that meet your eligibility, then you go into the text and do full text review. Now, sometimes when you do full text review, you realize that you don't have enough data. You contact the corresponding author of the papers to give you more data, and that often helps sometimes. And then you finally come down. So if you look at it, you started at 2,000 papers and ended up at 37, been a rigorous process, and this is where the work is. This is where the work for meta-analysis is. Now, once you've got your data, then you have to pull your data and clean your data. Now, pulling and cleaning the data is easier to do because you have your PICO. You follow your PICO to help you collect your data. So the data you're collecting, you want to collect data on particular participants, on an intervention, on a comparator, and on an outcome. And so you then assemble your data in tables. I'm not going to go into the statistical methods of doing meta-analysis using different statistical software, but often what happens if you're in a research group, you have a statistician involved. If you're doing a really big meta-analysis, it's really important to have a statistician involved because that often tends to help. But one added skill as a young researcher that is really good to have, my academic trainees have in the master of research degree, have to learn how to code in R or in Stata to do a small meta-analysis. I think it's really, really useful. When you're a full-time academic, it helps because then, one, you can understand and critically appraise meta-analysis better, but also secondly, it makes it cheaper because actually having a statistician is not particularly cheap, especially in this part of the world, but I'm sure it's like that everywhere. So you collect your data, and now at this point, when you've collected your data, it's really important to actually register your meta-analysis as well. So you've collected your data, you think you've got enough to do a meta-analysis, then there's a website called Prospero. So Prospero, if you Google Prospero, is hosted by University of York, and basically they will look through your meta-analysis plan, your PICO, and your outcome plan, and they will advise and agree to adopt your meta-analysis. Now, if there's someone else doing your meta-analysis already, that's where you know that someone's already doing it. But often, usually, you would know that from your literature search because they would have registered on Prospero. So you register it on Prospero, you collect your data, extract your data into tables, into outcome and number tables, and try as much as possible to avoid data duplication. Now, once you've put your tables together, you run it on your software, and you have certain outcomes, and I'll talk about later. But there's certain things that is really, really important to kind of understand. Bias is a really big thing with meta-analysis, and to reduce bias, that is why you as one person don't. If you want to do a really good meta-analysis, it should be done by just one person. You should have someone else. The more people, the better, just to reduce that incidence of bias. So you want to reduce performance bias, attrition bias, detection bias, and reporting bias. And there are different ways of looking at how these biases can be assessed statistically. So in terms of synthesis of data, this is when we go on to the meta-analysis. If you have enough data from all your literature search and from all your data, you then know that you have enough to do a meta-analysis. And once you've done your meta-analysis, you then interpret your evidence and then write a review. The Prisma website, which I've put under there, has a well-defined statement. It tells you all the sections you should have in your meta-analysis, all the headings you should have in your meta-analysis, and the Prisma guidelines. And actually, if you're submitting to a really big, high-impact journal, if you don't write your meta-analysis in the Prisma guidelines, you wouldn't get accepted. So that's really important to have a look at that. So just generally speaking, these are the advantages of systematic review. It's really good when done well. It's very good for decision making. It helps to inform practice and increases precision of results by combining data from different areas, different hospitals, and it makes the evidence more generalizable. But it has limitations because the location selection of studies and heterogeneity is a big problem in meta-analysis, because researchers don't talk to each other in terms of how they design their studies. So trying to put studies together by different researchers can be quite difficult. And nowadays, when studies are so heterogeneous, people tend to do subgroup analysis and try to deduce evidence from that, and sometimes that's inappropriate. So meta-analysis was first designed, described in 1976, as a statistical analysis of a large collection of data from individual studies. There are different types. There's cumulative meta-analysis. So, you do your meta-analysis, and every time a new study is published, you add one to it. Retrospective meta-analysis was most commonly done. You look back at those studies done before, and then you do a meta-analysis. And then we have prospective meta-analysis, where you do your protocol for your meta-analysis even before any studies are published in that area. It has very low bias. So as studies are being published, then you add it to your meta-analysis. Now, one thing that's really, really important on meta-analysis is your effect size. So there's no point, you're doing a meta-analysis and your total sample size, that's the total volume of patients in your entire meta-analysis, say 2,000 patients, and one study has 1,500 patients. That means that study is going to have an overarching bias in the results of that study. It's going to be skewed to the results of that study. So it is very, very important to, and in a bid to reduce that, there's some interesting statistical tests you can do, and that now informs what you use to actually rank and analyze your studies in order to actually synthesize the data to provide an overall outcome for the subject area you're studying. So this something is a bane, but it's also can be good if you have a lot of heterogeneity. You can do subgroup analysis to homogenize groups within your largest group that are more identifiable, and maybe you can deduce something from it. I think this is good for hypothesis generation. So if this is generating a hypothesis, then the next thing is to go and do a study for that group and then create the evidence there, rather than using it as evidence in itself. Sensitivity, you want to estimate the changes that could occur when some parameters are changed, and see how much that change affects your final results. And I'll show you in a minute when I show you a forest plot of how that looks like. So a forest plot, it shows everything. It shows your effect size, it shows your study weighting, your chronological order, and actually also gives you confidence intervals. And this is, if you're reading a meta-analysis, this is often, if you just want to look at what is this meta-analysis telling me, it is the one diagram to go to that tells you everything about your meta-analysis. Now, this is sort of the anatomy of a forest plot, and very quickly, I've stated there. So the studies are listed on the right. Often you would have a forest plot that also shows you the data from each study. The boxes in the middle are the effect sizes, and you can see that study is a bigger study, it's a small study, and the confidence intervals are the lines. Now the vertical line is a line on over effect, and what we've used here is odd ratio. And the key thing about odd ratio is that if you have an odd ratio that's greater than 1, it shows that if you're looking for benefit of something, it shows that that thing is beneficial. If it's less than 1, it is not beneficial. But if it's around 1, there is no effect. And so you combine, and the square at the bottom is a total effect. And this is what you look at, what the forest plot looks like. So this is a real study that has combined and done a meta-analysis. Now, if you look at there, there's a bit more data. One thing I want to highlight here is that one thing about really, really good meta-analysis is that they don't reflect really wide confidence intervals. When you have really, really wide confidence intervals, it tells you that there's a 95% chance that your effect could be anywhere in that confidence interval. If you have studies that have narrow confidence intervals, combining meta-analysis, your results are a bit more represented, and the data quality is actually better. So this is something to bear in mind. Now, heterogeneity is really important to look for. You could look at your forest plot and look for overlapping. If your confidence intervals are overlapping a lot, it tells you that there's no heterogeneity. But if they're not overlapping at all, and they're just so far apart, they're not overlapping at all, then there is heterogeneity. And you can do some statistical tests. You can do a chi-square test, or you can do an I-square test. The I-square test seems to have a bit more validity. And if you look at the bottom of your forest plot, you can see at the bottom there, an I-square of 58% is really good. If you have anything less than 25%, it shows there's a lot of heterogeneity, and you should look at that a bit more carefully and be cautious about interpreting that result. Now, what model will you use? This is a statistical thing. Do you use a fixed effect model or random effect model? Now, if you feel that there's really no difference between the studies you're putting together, and if there's any difference at all, it will be down to chance. Use a fixed effect model, and I'll tell you today that is very rare. It's very difficult to be so sure that there's no difference between your studies. But if your studies are there is a huge difference amongst your studies, and there's so many other reasons why there could be differences, it's best to use a random effect model, and that's what you'll find most of the time. And our advice, if you're doing random analysis, is to run both models and then see what you get. Publication bias. Now, to assess publication bias, we often use a funnel plot. And the funnel plot, what it does is you have this. I'll show you a picture. This is a funnel plot. You have an estimate of the 95% confidence intervals are the dotted lines, and then the studies, the size of the dots are the size of the studies, and you want all the studies even well distributed between the 95% confidence interval. When you have studies outside that, then it shows you there's a bit of bias. Now what kind of bias is it? You can't really tell. You could do some more statistical tests to tell what kind of bias is it. But if you're looking at a meta-analysis and most of the studies are outside the confidence interval, or they're not well distributed such that you have most of the studies at the top or most of the studies at the bottom, it shows that there is publication bias. And that's something to bear in mind in terms of the quality of your meta-analysis. Now, in terms of assessment of your meta-analysis, I think I've said this a few times, but I think it's worth saying again. Please look at the PRISM checklist. The PRISM checklist is really useful. It tells you all the steps you need to go. Now, in terms of what you've included in your meta-analysis, this is very, very good. This is used to assess the quality of the studies you put in your meta-analysis. So these are the guidelines, and I encourage you to actually look at this. And when you are assessing the quality of the studies you include in your meta-analysis in your screening stage, you should use these guidelines to assess the quality of the studies you're putting into. And you can use any of these studies to do a meta-analysis, an RCT, an observed initial study, a case report, a case review, or you can include a meta-analysis in a meta-analysis itself. Thank you very much. I'm sorry it's been a whistle-stop tour. There's a lot more to talk about meta-analysis, but I hope this has been a nice introduction and a teaser to get you to actually look at it a bit more. But it's an interesting way to do research. You don't need ethics to do meta-analysis. You just need to invest the time in it and get the studies together and do it properly. But thank you very much for the opportunity.
Thank you, Hakim, for that discussion of systematic reviews and meta-analysis. We're going to take questions at the end. I've asked the remaining speakers to try and contract their talk to just 10 minutes each, rather than the allotted 15 minutes. Sorry about that, and then we go on to any questions that we might have. So next, if I invite Dr. Ebere Ugu. Dr. Ugu is a plastic surgery resident at UCH. Thank you.
Thank you for the opportunity once again to represent the Audit and Research Group and to present one of our research works, which is on memorable learning experience, impact of school on life, and perception of clinical learning environment amongst nursing and medical students. And listed are the authors. The learning environment is the overall condition in which students operate during their study. It involves the structures, the curriculum, the socioeconomic and the emotional atmosphere. And students intimately interact with their educational environment, and their experience of it affects the quality of their learning. It also affects their motivation, success, and fulfillment, and central to this is their psychological safety. Psychologically safe environment lead to collaboration, positive learning experience, and ultimately effective healthcare practitioners. There's evidence that the learning environment can be measured and improved in order to enhance the quality of the learning process. Our study aimed to assess the perception of the clinical learning environment of medical and nursing students, and it was approved by the joint University of Ibadan and University College Hospital Health Research Ethics Committee. It was a cross-sectional study carried out in November 2021 using 2 validated questionnaires, the Dundee-Brady Education Environment Measure, as well as the John Hopkins Learning Environment Scale. We also added 2 open-ended questions, one on the memorable learning experience, and then the second one on the impact on life, impact of medical and nursing school on their lives. The dream questionnaire consists of 50 items that were subdivided into 5 subscales, and the answers were graded using the Likert scale, and the maximum obtainable score was 200, with score greater than 100, indicating a more positive than negative perception. The John Hopkins Learning Environment Score consisted of 28 questions that were subdivided into 7 domains, and the maximum obtainable score was 140, and a score of 90 was regarded as a more positive perception than negative. Data were collected from clinical medical students as well as first to third year nursing students, and they were analyzed using SPSS version 23. For the open-ended questions, an inductive approach was used for the coding and thematic analysis. The mean scores were interpreted as either positive or negative and were correlated with the student's course of study. One 93 students completed the validated questionnaire. However, only about 39% of them answered the open-ended questions. And this table shows the socio-demographic characteristics of respondents with a mean age of 22 years. Most of them were medical students, 78.2%. Were in their third year of study, 33.7%, and were females, 54.4%. The mean total dream score was 111, which was more positive than negative. However, when we looked at the different subscales, we found that the subscale perception of the atmosphere and the social self-perception were more negative than positive. This is the list of questions that are under the perception of atmosphere domain. And then these are the list of questions that are under the social self-perception domain. For the mean overall score for the John Hopkins Learning Environment Scale was 91, which was also more positive than negative. And this was the same pattern in all the 7 domains. This table compares the relationship between the dream scores and the course of study, and we found a statistically significant difference between the course of study and the students' academic self-perception, as well as their perception of the atmosphere, with nursing students having a better academic self-perception than medical students, while medical students had a better perception of their atmosphere than nursing students. This is a table comparing the dream scores from our study with previous studies. And you can see that the studies involving the medical students, that the social self-perception subscale had more negative than positive perception across the studies involving the medical students when compared to the one involving physiotherapy students. And also, most of the studies involving medical students also had a more negative perception of atmosphere than positive. For the open-ended questions, there were a combined 116 answers, which were graded on a Likert scale from 1, very negative, to 5, very positive. About 29% of students gave a negative response. However, none of the students answered both of the questions negatively. This is a transcript from a response to the impact of medical or nursing school on life open-ended question. After going through the transcript, the meaningful sentences are then coded into single words or phrases as shown on the right. And these are then arranged to form a theme, which then builds the narration of around the theme. Now, if you look at this transcript, you'll find out that there is a negative comment there about broken people break others. However, when we looked at the overall picture, it was a positive one, and therefore it was graded on the Likert scale as 4, which means good impact. Listed are the overall themes for the memorable learning experience question, and include novelty, enhancing experiences, learning environment, atmosphere, and psychological effects. And in bold are the direct quotations from the students. Now, the learning environment, atmosphere was a recurring theme, and the direct quotation was about a lecturer changing a very tense atmosphere that was created by a previous lecturer that had just concluded the lecture. The listed are also the overall themes for the impact on life of medical or nursing student school, and I'll mention the narration under this one after the other. For the personal development, it reflects the effect of the learning environment on students' development, and once again, the sentences in bold are the direct quotation, and the narration include social and intellectual development, development of problem-solving skills, attitude to excellence, and motivation to be better people. The quotations include, it has taught me the value of hard work and determination from whatever I seek to do. It also continues on this slide. There is a direct quotation. It has given me the purpose and direction required to live one's life. I have engaged in activities that now give me an idea of what I want to do with my life to a certain extent. It also includes skills, improved time management, importance of teamwork, as well as positive effects on personal lives, orderliness, and cleanliness. However, for some, the desire to practice medicine is uncertain. For aspirational refers to things that make the students to aspire to do more, and one of the direct quotations under that include, I see so much sicknesses and death, and it makes me appreciate the severe absence of such in the lives of those that I hold dear. It has also woken me up to the reality of the struggling healthcare system here and provoked me to strive for change. Now I have a real desire to establish a lasting mark in the healthcare system by my practice and by the establishment of as many healthcare clinics as I'm able in the future. Then the psychological refers to activities that could have effects on the psychological well-being, and the narration is here. The next slide. There is also a direct quotation about the students learning to survive in a toxic environment. Next slide. I don't know if you can go back. Okay, so a student writes and said, I do not want to end up as the consultant That is, if I end up in clinical medicine, which I doubt, which is means to students, means to registrars and senior registrars for no reason. He continued, I do not want to be a perpetrator of the negative cycle in medicine, where we do bad to others because they had been done unto me. And another student also added, has this to say, he had made me see that broken people break people. Overall, in both the validated questionnaires and the open-ended questions, there are a lot of positive things to take from them. However, this is better summarized by the personal impact of medical or nursing school on the personal development of the students, such as value for hard work, motivation to be better people, social and intellectual development, purpose and direction in life, aspiration to serve humanity. However, 29% of students who answered the open-ended questions had poor or very poor memorable learning experience, or the impact of the medical or nursing school on them has been poor or very poor. Things like learning to survive in a toxic environment, depression because enjoying life is rare due to the hectic schedule, and their desire not to end up as a consultant who demeans people, and broken people break others. Negativity is the enemy of good. Therefore, whatever positive benefits of being a medical or nursing student are psychologically unsafe environments, even for the very few, lead to negative psychological sequelae, poor overall learning process, and healthcare practitioners that are ill-prepared for the future. In conclusion, despite the overall positive picture of clinical learning environment, there are significant areas of students' welfare that need to be addressed, especially the atmosphere of learning and the social aspects. We've also done a focus group discussion to further elucidate these areas, which is undergoing analysis. More work is needed to improve students' learning environment. Thank you for listening.
Thank you very much, and apologies to have to rush you at the end. If I can invite Dr. Habib Ogundikwe to give his talk on the audit of use of WHO surgical checklist and attitudes in UCH. Dr. Habib is a pediatric surgery resident here. Thank you.
Thank you, sir. Good evening, everyone. I'll be showcasing one of the works of the Audit and Research Group of IMSG, titled The Audit of the Use of the World Health Organization Safety Surgical Checklist at UCH, which will be followed up with a survey on the attitudes of surgical team members to the checklist. The checklist was developed in order to attend to the preventable causes of morbidity and mortality, as well as in the immediate post-operative period, by promoting communication amongst the team members, as well as ensuring that the safety checks are done as at when due. The checklist consists of 19 items, which are divided into 3 separate phases, and these phases are to be taken at different periods of time: the sign-in phase, the timeout phase, and then the sign-out phase. This is what it looks like. There are 7 questions on the first, 7 questions on the second, and 5 questions on the third. And this would usually taken by the circulating nurse in theater. Usually taken by the circulating nurse in theater, although it could be taken by any member of the operating team. And is the first phase is taken with the anesthetist and the scrub nurse, while the other phases includes the surgeon as well. And it is advocated that it's used for every surgery. Studies have shown that implementation of the checklist helps to reduce the incidence of surgical site infections and preventable causes of mortality in the perioperative period by about 50%. And thus, it is encouraged that all hospitals should domesticate it for use in their theater. Okay. There had been a previous study by some of our trainers Hendrickse et al. In 2015 completed a 2-year audit of the checklist at UCH, and which was published in the official journal of the College of Medicine, as shown above. The major findings were that it was virtually used in almost all surgeries, and that there was good knowledge of the checklist among the among the operating team, although the surgeons did feel that it was a waste of time. The aim of our audits was to look at any change in trend, to know, to assessing the use of the checklist at the theater, and to see the gaps, and then assess the knowledge and acceptability of the checklist by the theater personnel. So, during a 1-month period, we conducted a survey by visiting the theater suite of different, while different surgeries were ongoing, and the events were captured in a pre-developed questionnaire which we developed ourselves, and the data was analyzed using SPSS. So over the 1-month period, 117 surgeries were observed, and these are the different specialties that had surgeries that we observed, and about 60% of were general surgery and urology. Surprisingly, only in about half of these surgeries was the checklist used. And it was noted that minor surgeries were not likely, were the surgeries that they were likely not to be used, as it was only used in about 5.4% of the minor surgeries, and this was statistically significant. Also, in the timeout phase, which is the phase at the time just before the surgical incision is made, all team members ought to stop all they are doing in order to attend to the 7 items at this phase. But you notice that more than three-quarter of the situations when it was administered, this was not done. Also, we also talk about the completion phase of the checklist, in which it is not enough to just administer it. All of the questions needs to be read out, and we put completion at when 5 or more questions are administered. And I would say that the completion rate is quite low for all the phases, particularly in the sign-out phase, with a completion rate of 7.7%. Now, looking at the specific questions in the areas that were not completed, we looked at the timeout phase and the sign-out phase. And of importance here is the ones bolded in red, whereby because it's a nurse that administers the questionnaire, but we noticed that the nursing team, more than half of the time, were not asked the questions on these areas, which was quite significant, and it was significantly different from the questions that were supposed to be asked to the anesthetists and the surgeons, which were more likely to be asked. Also, at the sign-out phase, as we said, was the least completed out of all the phases. And we see significant, in almost half of in situations where it was administered, critical questions were not asked, such as the name of the procedure, labeling of the specimen, key concerns for surgery, and quite notably, asking whether there were equipment problems during the surgery that needs to be addressed before any other surgery, which was missed in about 3/4 of cases. So summarily, the checklist was only used in about half of the surgeries, and it was commonly not used for minor surgeries, and often not completed half of the time, especially with the sign-out phase. And the coordinator of the checklist, usually a nurse, was more likely not to ask the nursing team questions directed at them at the time-out phase. We followed this up with a questionnaire on awareness, perception, and accessibility of the checklist by surgical team personnel, using a 15-item self-administered questionnaire, and 81 personnel took part in this survey. Half of the respondents were surgeons, and a quarter were about nurses and anesthetists, and more than half of them have had more than 5 years experience working in UCH. Most of the personnel came in contact with the checklist for the first time in theater. It's about 2/3 of the respondents. However, when it comes to formal training, Also, about 2/3 of the respondents had not had any form of formal training on the use of a tool that helps to prevent 50% of preventable deaths and surgical site infection. About three-quarters of the personnel noted that a perioperative nurse should administer the checklist, which we believe is from experience, as that is who normally administers it. However, 6% rightly alluded to the fact that any medical personnel that is part of the operating team could administer the questionnaire. More than 90% rightly chose that the administration of the checklist should begin before the induction of anesthesia. And most of the respondents agreed that it is beneficial to be used for both minor surgeries and major surgeries, though to a later extent for the minor surgeries. Among the respondents, about 38% had made errors during surgery, and out of these 38%, 28% of them agreed that if the WHO surgical checklist was implemented, those errors could have been averted. When we looked at the perception, which was evaluated with a series of questions, and we put the scores together, so greater than 15 was said to be positive, and less than 15 was said to be negative perception. I'm sure that only less than a fifth of the respondents had negative perception, and this was not related to the profession of the respondents. Now, this corroborates our findings at the audit and when respondents were asked about the level of implementation of the safety surgical checklist based on their own experience. And we will also note that the timeout phase and the sign-out phase, especially the sign-out phase, have low level of implementation, just about 27.2%, again corroborating what we said earlier, what we found earlier during the audit. And it was quite acceptable as a tool that prevents perioperative adverse events. In summary, majority of the members of the surgical team had not had any formal training, but there was good awareness on the use and the benefits of the safety surgical checklist, and there was a high level of positive perception about the role of the checklist in promoting communication and teamwork among members of the team and improving patient safety. The implementation of the phases of the checklist waned off, especially after the induction of anesthesia, and surgical team members accept that the tool is good in prevention of perioperative adverse events. We also noted that there was no difference in the awareness, perception, and acceptability based on profession of the respondents. Our recommendations are that there should be a formal training, and that the checklist should be available at the theater and should be used for all surgeries. And the coordinator of the checklist should ask all questions aloud and should ensure that all the phases of the checklist are administered at all times, and that all members of the surgical team should stop to attend to phases of the checklist as required. The other areas for research would include looking out for the barriers to the safety surgical checklist and looking out for modifications based on local findings that we think need to be included in the checklist as advocated by the World Health Organization. These are references. Thank you.
Thank you, Dr. Ogundikwe. Particularly pleased that you could pivot to shorten that presentation into 10 minutes, so well done. The final talk we have is from Mr. Olufunsho Adedeji, our outgoing Education and Research Secretary, who has done so much for IMSG. Mr. Adedeji, thank you.
I think Habib was terrified of Dr. Gunyemi, so he finished his lecture very quickly. I'm equally terrified as well, so mine will be finished as well. For those of you who are here, there's some leaflets that Mr. Banji has given out for you guys if you want. There's not an awful lot to talk about, actually. I think I'm just going to go a bit summary in terms of the research audit group, and just I think about 4 slides. just about 4 slides, that's better, on collaborative grouping. Just really to talk that we set up this research group in 2021, and 8 residents started, joined the group. There are about 14 now. Next slide. Then obviously I think that since we have a lot more residents here and online, I think about 40 people in total who are joined up to all of this. I just shared the online survey that you guys did, which I haven't shared since it came out, since we did it 2 years ago. 37 people filled the online form, and 43% were senior residents, and 84 were males. Next slide, okay. General surgery and orthopedic surgery were the 2 largest departments of residents. Next one. At the time, 65% of residents had not done any audit or research since graduation. And I know that looking at the back figures for this included people who were in the final year of training. Next slide. And only 9% have completed the audit cycle, and Mr. Adeyeju explained what a completion audit cycle is, so I won't go into that. Next slide. 100% of surgeons, of you that feel this, believed that all surgeons should do audits, and 100% of you believe that it's good for clinical practice. Go on to the next slide. And even more surprising, 95% of you thought you should do at least 1 or 2 audits every year. Next slide. However, in answer to the question, do you want to do an audit this year? Only 2/3 of you said yes, and a wonderful 1/4 of you said you don't know. Next slide. And going further, 75% of you have never made any oral or poster presentation at any national or international meeting. Next slide. 65% of you have never been an author on any peer-reviewed paper. Next slide. 97% of you indicated that you want to take part in a study or audit, and encouragingly, most of you disagreed that this is just to pass your fellowship, so you have better reasons for wanting to do a research study or audit. Go on. So what are the reasons why so many of you trainees in the biggest teaching hospital in the country and in West Africa, you haven't done research? The most important reasons that you gave was, I don't know where to start. The second, no, go back to the slide. The second was, there's no support. But what is surprising was the joint third. Source of funding, that understands it, but it's the second one that says it's not a culture in our environment. And that I found surprising in a big teaching hospital. Next slide. And surprisingly, the fact that the vast majority of you haven't done any research or any audit, the vast majority of you want to work in a teaching hospital, which I found very surprising. Next slide. So for that reason, we started the research group. Of the original 7, 5 have never done an audit, 3 not done any research work, and 3 have not been authors. And by a series of voting, we obviously agreed on the 2 papers you've already listened to today. Next slide. The WHO checklist was supported by the HOD, Professor Ogunlade, and over a month. I won't go into that. Next slide. And that's, you've had a presentation of that this afternoon. Next slide. And then the second one was learning environment, which Professor Owaje helped co-supervise. We sought ethical approval, and when we were here 2 years ago, the interview with the medical students happened. Next slide. And on that part, they've actually done a focus interview as well, and that's yet to be analyzed. And the poster presentation of this was done at the Association of Medical Educators of Europe in end of August, was presented as a poster. Next slide. Next slide. You've already heard. So just briefly, I think the whole idea about research collaboration is a group of people working together to try and get. I think you heard Professor Waje in an earlier presentation talking about most research that gets funding is about collaboration, albeit not collaboration in one institution, but across institution and across specialty. But I think in terms of this, the whole idea of getting you guys to do some work is that you probably need to work as a group, and that gives a lot of motivation. I've been impressed by all the trainees and what you've been doing over the last couple of years. But it's a structure if you want to do collaborative work. Next slide. And this is really just more about making a successful collaboration, and that involves that, one, you have to decide that you have a committee, you have a group of people, you work together. You need to decide what you want to talk about, how you go about it, and how you get funding. And I think that's the reason why we asked Professor Oweje to speak to us to that. And you have to foster a cohesive spirit. So it's everybody in it together, and not just one person. Next slide. What's the reason that it's important that you guys do the research? And as, again, I have to go back to Professor Oweje. As she said, people come to this part of the world for 2 months, and they become experts in sub-Saharan Africa. But you are the expert, and I think that from today, there are a lot of things that are different that happens, and when you read the major textbooks, it's about what happens in the world, but not actually what happens there. So from the WHO audit, what are the reasons why the WHO, I do WHO surgical checklist every single day of my career in the United Kingdom. And I lead it. I do all the reading because that's the way we do. But why doesn't that happen in almost 48%? And those are the things you need to look at. And I think you suggested adaptation. We heard Professor Gunteron earlier today. Over 80% of women still present in stage 3, stage 4 breast cancer. That needs to be looked into. What are the attitudes to mastectomy and how to tackle those attitudes? Those are answers for local research people, including the molecular differences. Colon cancer, Professor Irabo spoke to us about 5-FU efficacy, and that's because of the molecular differences. And those are the things that it's researchers in these places that are going to answer those questions. Next slide. And just, I think that's probably my last slide. Just as a aside, look at cancers. These are cancers. And if you look at the role of infection in causing cancers, Sub-Saharan Africa, 31% of cancers are secondary to infection. And where all the research and all the money goes, and where all the textbooks come from, North America and Europe, Europe is not here, North America and Europe, less than 4%, 5% of cancers are due to infection. So the research and the textbooks that you have doesn't totally address what you have in this environment. So I think that the building a culture of research and audit amongst our trainees is the way forward. Next slide. Thank you. I definitely escaped, Doctor.
Thank you, for sure. I did say that we would have questions and answers. I'll start the ball rolling by asking a question of, this was intended for Banji, but since that Banji has departed, Funsho, it falls to you and Dr. Ogundikwe. What are the main barriers that you see in this environment to developing?
As I said, one of the things that we had identified earlier is most of us prior to this time did not know how to conduct an audit. So not knowing where to start from, it's one concern first. The other thing about it is the report. How is it taken? Would it be an avenue to, or like, which one? The person that is presenting it, the perception of, especially when it's a younger person doing the audit of its own practice, and the perception from the superiors might be a thing of concern, but I think it's something that can be overcome.
Any other questions or comments? I can't actually see anyone, so I might just crack on. Thank you, Amy.
So in terms of the last comment, I think it's institutionalizing the audits and making it like the chart review. If once it's done like that, people will not look at it as a witch hunt. Definitely change is always a problem, but with the results that you've gotten, that's part of the research outcome and research impact. You go back to the Department of Surgery that has a buy-in, already had a buy-in, and say, look, we need to up our game to international standards, and we need to conduct these audits regularly. And that way, they can take it up to the management level, and it becomes part of the institutional culture. There's always somebody that starts a change in culture. Thank you.
Thank you, Amy. I'll go on to ask, I have a raft of questions, apologies. Dr. Olaloru, when you were describing the qualitative research and quantitative research, two things occurred to me. That one, are there some research questions that you think either method would be suitable rather than one or the other? And secondly, how do the costs tend to compare in practice in terms of going for qualitative or quantitative research?
Thank you. Great questions. So regarding whether you would want to do qualitative or quantitative, I think a lot depends on the way you frame your question. There are some questions that you could use both approaches for, and you can go for a mixed methods approach, but there are some that are purely quantitative, even in the way they're framed. For instance, if you're looking for the prevalence of colon cancer in Nigeria, you definitely would be asking a quantitative research question, and there's no room for qualitative research there. But if you're trying to understand the recovery of colon cancer patients that are admitted in a tertiary teaching hospital and the impact of their disease on their families, then that would be a more qualitative question and would require qualitative approaches. As far as mixed methods, one of the examples I gave was on barriers to accessing family planning services for older women. That could be a mixed methods approach. You could have a list of barriers that you would include in a survey, but then you can also have focus group discussions to generate even more barriers so that you can understand the problems that older women in a culture that assumes that older women are not sexually active would face if they're trying to seek family planning services. Regarding the cost, I think it depends on the skill. Qualitative, because you're generally working with a much smaller sample size, tends to be cheaper, but not necessarily so. For instance, if you're doing a mobile phone assisted survey and you are able to use mobile phones that you already have or that you're borrowing at no cost, it could be just about the same cost as doing an average size qualitative study. So it's relative. It depends on your sample size, the number of people you're trying to reach out to, and the actual tools and methods that you're using. But in broad strokes, I think qualitative tends to be cheaper than a large-scale quantitative survey.
Thank you for that. Any questions? Any other questions? Amy? Huh? Not online. Okay, thanks. Professor Waji, A quick question. In your talk, you gave a very informative description of how to go about the applying for a grant, and some of that is quite specialized and not widespread knowledge that can be difficult to come about. And I wondered whether one, there is a need, or secondly, whether there is the space for a centralized administrative function that helps, that pulls together all the grants applications from an institution and helps them go through it in a smooth way and uses the sort of accrued and experiential knowledge that yourselves and other successful grants applicants have accrued over the years. Just your comment on that.
Thank you. Yes, the University of Ibadan established a research management office in 2010, which I had the privilege of being the foundation director of. And then within the College of Medicine, there's a college research and innovation management office where I'm currently the chairman. I provide executive oversight function for. But the issue we have is that we don't have enough staff. There's definitely the knowledge that we need to build that capacity, but the staff do try to do.
Not here in absentia for giving us the space to be able to have this. Thank you to the residents and everyone online who has participated here. Thank you to all our speakers for their excellent talk. I think you will agree with me that the talks have been full of a lot of practical gold nuggets that anyone interested in research and audit can take away. So can we give a round of applause, please, to all our speakers? Before we depart, I'm just going to have a small mention of Mr. Funsho Adedeji. This is his 8th year of being an Education and Research Secretary in IMSG. And I think this event is his swan song in that capacity, as the last one is actually organized as the Education and Research Secretary. He's still the editor of our Journal of Global Medicine, and we still hope to get more sweat from him in IMSG. He has been a wonderful contributor to IMSG and our vision, and we are very, very grateful for his diligence over these years. But if you all join me in appreciating Mr. Adedeji. So thank you to everyone online, thank you. And with that, I call this event to a close, and I bid you all a good evening. Thank you.